Mr. Tawfiq Elahi. I'm presenting hand injuries in climbers on behalf of my co-authors and Parcels NHS Trust. The aim of our study was to look at the different types of hand grips used in outdoor and indoor climbing, frequency and demographics of the hand injuries, and meta-analysis of current treatment in view of the current literature. So we looked into the common and uncommon grips. You can see the 4 common grips, cream being the commonest, and there are less common grips. It is very important for the cream grips because, as you can see from the results, that the commonest injury being the pulley injuries, and other injuries involve fractures or tendon injuries. Because of the cream position, the finger is positioned with the flexion of the PIPG and hyperextension with the pressure on the index finger with or without the thumb. And that's why the injuries, pulley injuries are commonest, and A2 pulley being the commonest because it provides maximum load onto the pulley. And the maximum breaking pressure for the A2 pulley injuries is about 408 newtons, and usually with the cream position, the usual pressure applied is around 380 newtons, so there's not much of a difference. So as you can see, in terms of treatment, they can be treated both conservative or the surgical, but so according to the grading of the injury, so grade 1 to 3 can be comfortably treated with conservative management with early involvement of the hand therapist, or surgical for the grade 4 injuries, which involve multiple pulley injuries with or without fractures or lumbrical injuries. So different conservative options include taping, pulley splint, and rehab exercises, which includes tendon glides and claw stretch. So you can see different forms of taping: H taping, 8 taping, or circular taping. H being one of the most commonly used taping techniques. Surgical techniques depends on pulley reconstruction. There are different techniques discovered different surgeons depending on the surgeon preference. There are some photos of this. So from our study, we can conclude that the recommendation for grade 1 to 3 injuries, it could be treated conservatively, and grade 4 injuries should be treated surgically. And it is very important early involvement of the hand therapist from the very beginning throughout the journey to have a successful outcome. That is the end of our presentation. Thank you, ladies and gentlemen.
Good evening. I'm pleased to present our work from the Queen Elizabeth Hospital in Birmingham, looking at circular saw injuries of the hand. We know from experience that these are common injuries seen in our clinics and our theatre lists, and we sought to assess, quantify, and stratify the exact burden of this group of patients. We searched an electronic hand trauma database from a tertiary hand surgery unit in Birmingham, and we looked at all machinery-based injuries occurring from 2017 to 2019 inclusive. We then performed sub-analysis of all those involving a circular saw of any make, size, or model. We identified 1,486 power tool-related injuries, of which just short of 400 were related to circular saws. 97% of those involved were male, and it should be noted that those that were female, only 3 were actually holding the tool at the time of the injury, while others were holding the device being cut. The average age was 47, the range extending up to 95. 351 were right-hand dominant, consistent with national averages. Greater than national average number were smokers, and again, alcohol consumption was higher in this group than the national reported average. We saw 61 carpenters, 57 builders, and 39 other tradesmen of non-specific type. 14% were retired, and 5% of individuals were unemployed. There were 4 doctors in our case series. The population matched national averages with regards to diabetes and hypertension. This is our heat map of where injuries commonly occurred, and you can see that its most usual is the left index finger, followed by the left thumb and left middle finger. This was irrespective of hand dominance or the style or mechanism in which they were using the saw. A quarter of cases were tip amputation, meaning the loss of soft tissues distal to the distal tip of the distal phalanx. A further 15% of cases were more proximal, involving the nail bed. 10% of cases had a fracture requiring stabilization, and 68 cases had an identifiable digital nerve injury pre-operatively, with a further 12 identified intraoperatively. Extensor tendons were more commonly injured than flexors, and it was unusual to have a zone 2 injury lacerating both the FDP and FDS tendon. We had 11 replants during this time, of which 7 were thumbs and 4 were multi-digits, although it should be noted there was a local policy not to replant single digits that weren't the thumb. 70% of these patients were managed in an outpatient setting. So in conclusion, circular saws are a common cause of hand injuries and a burden to ourselves and the NHS. 50% of these injuries occurred within the home, either in a DIY or an off-duty setting. The left hand is significantly more commonly injured than the right, irrespective of hand dominance. The majority of these patients can be managed in an outpatient or treatment room setting. We see this as an opportunity for a preventative public safety campaign led by the BSSH alongside organisations such as ROSPA to try and reduce the frequency that these injuries occur.
Hi, my name is Ian Shelton, an occupational therapist from the Pulvertaft Hand Centre in Derby, and I'll be presenting our audit data on flexor tendon rehabilitation. In 2016, our centre implemented the Manchester short splint as described by Peck et al. For single flexor tendon repairs in Zone 1 and 2. Following the success of this, in 2017, we broadened our inclusion and exclusion criteria to include patients with multiple tendons, uncomplicated fractures, and digital nerve repairs. The aim of the study is to assess the outcome of our pragmatic use of the Manchester short splint for Zone 1 and 2 flexor tendon repairs. Hand therapy notes in 2016 were retrospectively recorded and then prospectively from 2017 to 2019. Strickland scores, extension deficits and complications including ruptures were recorded at 12 weeks. 154 patients were treated with the Manchester short splint from 2016 to 2019. Of those 154, 52 patients were immediately transferred for local hand therapy, so were excluded. 12-week data was available for 87 digits in 72 patients, which gave us a 71% follow-up rate. Strickland scores were measured at 12 weeks, demonstrating initial results were promising. However, by 2018, we had 94% of digits scoring poor and fair, and only 6% good, a reduction from previous years. After altering guidelines to increase active repetitions and flexion, and adding dorsal extension splints for any PI-PJ deficits, 2019 Strickland scores were poor and fair in 57% of digits, and good and excellent in 43%. Extension deficits of the PIBJ have remained above those reported by Peck et al. With adjustments of the protocol, deficits improved from 2018 and are continuing to be proactively treated. The rupture rate per digit was recorded and was similar to Peck et al. Until 2019. Of these 8 ruptures, 3 were associated with infected wounds, 4 were a result of non-compliance, and 1 was an unknown cause. Results were concerning in 2018. But after clinical adjustments were made to the rehabilitation guidelines, results improved significantly. This included splinting any extension deficits earlier and increasing both passive and active range of movement exercises to reflect the confidence of repairs being used. 2019's results matched the Strickland scores of Peck et al., which only included simple tendon repairs. A high rupture rate was noted in 2019, however, has been justified and explained. The Manchester short splint, if implemented with the correct therapy regime and clinical justification, demonstrates its potential use for more complex flexor tendon repairs in Zone 1 and 2. High quality evidence is recommended and needed to investigate its success.
Good evening, my name is Alva Kiley and I'm going to talk to you about functional outcomes following the management of phalangeal and metacarpal fractures in children. So the aim of this study was to assess range of motion post-manipulation and splint, percutaneous K-wire fixation and open reduction internal fixation across 10 years of phalangeal and metacarpal fractures in children. So for the methods, this was a retrospective study. Patients were grouped by location of fracture. Function was measured by TAM scores as outlined by the American Society of Surgery of the Hand, where a good score equated to 75% of the range of the contralateral digit. They were then compared by treatment group. Most fractures occurred in males as a result of a fall or a sporting injury. The most common fracture of all was the little finger proximal phalanx fracture, and the most common metacarpal fracture was the 5th. So P1 fractures that underwent manipulation had a higher proportion of good functional outcomes than K-wire or RF. Middle phalanx fractures had overall excellent functional outcomes with no difference between treatment methods. Distal phalanx fractures had significantly worse outcomes, but there was no difference between treatment methods. And notably, phalangeal fractures that occurred in the thumb had significantly worse outcomes than those in the long fingers. 48 metacarpal fractures were compared by treatment, which saw no statistical difference in outcomes across all managements. Again, outcomes were significantly worse than the thumb. So this scatter plot shows the degree of post-reduction angulation on a scale of 0 to 60 for fractures that had a good or fair functional outcome. You can see that angles of up to 50 degrees in both planes are tolerated at this peak of functionality. Finally, on univariable regression analysis, fractures in the thumb were predictive of a poor or fair outcome. Overall, this study has shown that fractures occurring in the child's hand have favorable functional outcomes, with 78% achieving a TAM more than 75. We found that phalangeal fractures did better with simple manipulation than with metalwork. Fractures in the thumb did worse than those in the long fingers, and there was no relationship between the perfect reduction and good function. The biggest limitation of the study is its retrospective design, leading to selection bias into treatment groups, i.e. a more complex or angulated fracture is more likely to require metalwork. So on the basis of this study, we recommend that these fractures are paid close attention to and follow-up in the hope of maximizing range of motion. Thank you for listening.
Good evening, I'm Deepak Samson. I'm the Orthopedic Hand and Wrist Fellow at the University Hospitals Coventry and Warwickshire. I'll be talking to you today about the potential for ambulatory care management of animal bites to the hand. Our old protocol for management of bites called for inpatient admission for all bites with IV antibiotics and elevation on the ward. All patients were then booked on the next available hand trauma list for formal surgical debridement in theatre. Towards the end of 2018, however, due to the NHS winter bed pressures, we found it difficult to admit all our bite patients. This led us to think whether we could safely avoid hospital admissions for these patients altogether. Following a discussion by the senior author with our microbiologists and access to dedicated hand trauma lists 6 days a week, which we didn't have earlier, our management protocol underwent a paradigm shift. Based on the available evidence, the microbiologists and us concurred that oral antibiotics were as efficient as IVs, and thus we drew up our new protocol. This called for a thorough wound wash under local anesthetic in the A&E, with the patient being sent home then on oral antibiotics with a sling and brought back for surgery the next day as a day case procedure. The exceptions, of course, were patients with signs of overt infection at presentation. When this protocol was in place for about a year, we performed a retrospective audit to make sure it was safe and effective. We looked at 4 consecutive months of data, each under the old and new protocols. As indicators for safety, we used unplanned reoperations and the development of osteomyelitis. We looked at time to surgery and days of inpatient stay as markers of efficiency. We also did a cost analysis of patient episodes under the old and new protocols. There were 36 patients treated under the old protocol between September and December 2017, and 37 patients treated under the new protocol between September and December 2019. The number of bed days had gone down from an average of 2.36 to 0.53. The time to surgery was quicker, and the complications had come down as well. The average cost per patient episode had decreased by close to 40%. To conclude, we found the new protocol to be both safe and effective from the patient and trust point of view. Taking it further, our findings could support formulation of broader guidelines for the management of these injuries as well. Also, in light of the recent data on surgical site infections presented at the BSSH Journal Club and published in the JHS, showing no increased infection rates with delayed surgery even up to 4 days for open injuries, it may be that we need to change our perceptions on how aggressively these injuries need to be treated altogether. In fact, we're now looking at the animal bite injuries treated during COVID in our minor ops room to see if that is the way going forward as well. Thank you.
Thank you for inviting us to present. My name is Theodora. I'm a plastic surgery registrar at Guy's and St. Thomas's Hospital, and I will be presenting a project, a standardized hand fracture fixation training framework for surgical residents using novel 3D printed ex vivo hand models. All the models used for this project were manufactured by a company that I'm a co-founder of, and the aim of the study was to create a standardized simulation training module for hand fracture fixation with K-word techniques for plastic surgery trainees that will prepare them for their first encounter in the clinical setting. The study was designed using a step-ladder approach training with 6 levels of difficulty on K-wire techniques, included 20 residents, 10 junior and 10 senior. All the models were 3D printed models, and the validation tests were the assessment of the skills of the trainees in the beginning and by the end of the module on the 5th metacarpal neck cross K-wire fixation. There were 6 levels of difficulties. The first level was a mallet finger fracture fixation, which could be done on the finger bone model shown in picture C and D. Level 2 is the metacarpal shaft fracture shown in picture A. Level 3 is the dynamic X-fix shown in picture D. And level 4 is the metacarpal neck fracture, the proximal phalanx fracture that can be done on the hand, which is embedded in silicone. And level 5 and 6 is the reverse Bennett's and Bennett's fracture, both in the silicone model. The validation test assessed different aspects during the task, from scoring 1 to 5, and that included the instrument handling, hand model manipulation, efficiency in completing the task, using of CR with economy of movements, final position of K-wires, minimal attempts for K-wire insertion, satisfactory reduction with no rotation deformity, adequate use of the assistant. Maximum score was 40. There was overall significant difference between the improvement of the skills in the beginning and by the end of the course, and all trainees confirmed the high fidelity of the models and the fact that the models helped them improve their understanding for the 3D bone topography. If we pay closer attention to the p-values, the junior residents had much more improvement of their skills, and the senior residents were the one that improved more on the adequate use of the assistant, which is a skill that is further developed when you're more experienced. In conclusion, there was significant improvement of the trainees towards these techniques, and we have shown that 3D printing is a technology that can potentially become mainstay in developing biomimetics for the training of the hand surgeons, and particularly those on the early stages of their learning curve. Our vision is to combine our models with VR technology in order to provide simulation training for other fracture patterns and surgical techniques, and inspire other units to adopt our training module and collaborate in order to further develop the simulation training for hand surgery. We are planning to create a hand training lab in plastic surgery departments where trainees can practice their skills on K-wire techniques. Thank you for your attention.
Good afternoon. My name is Diana Asberia, and I'm going to present this study on behalf of my colleagues at St. Andrew's Center in Chelmsford. The use of intramedullary compression screws in hand surgery was first described in 2010 for fixation of a metacarpal fracture. However, since then, there's only one study reporting its use in the treatment of phalangeal fractures. The aim of our study is to present the outcomes of this technique in the treatment of both metacarpal and phalangeal fractures. We conducted a retrospective case series in which we included all adults undergoing this type of fixation of single or multiple fractures between December 2015 and August 2019. We also included open fractures. All fracture had a retrograde approach with the minimal dorsal incision and longitudinal split in the tendon. Reduction was maintained with a guide wire, and screw was advanced with no pre-drilling and buried under the articular surface. Patients did not require splinting, and they were mobilized by the hand therapist within the first week. We identified 35 fractures in 26 young patients, 16 metacarpal and 19 phalangeal fractures. The most common pattern was transverse shaft fractures in both groups. The mean follow-up was 11.7 weeks. Total active range of movements for all fractures was 72.5% of the norm, which can be considered a good outcome. 3 of our patients developed CRPS, which resolved with corticosteroids and physiotherapy. And to mention is that all 3 had multiple fractures requiring fixation. One of these patients with an open fracture developed osteomyelitis. He required long-term IV antibiotics and osteosynthesis removal. This is an intraoperative photo from when the screw was removed. He achieved fracture union and a total active motion of 180 degrees. In conclusion, our results replicate the good outcomes reported in literature to date, and also adds evidence with a large cohort of phalangeal fractures. As one of our patients developed osteomyelitis with an open fracture, the question arises whether this type of fracture imposes a greater risk with this type of fixation. Our study carries the limitation of a retrospective study, and prospective cohort studies and randomized controlled trials are needed to add more evidence. With our preliminary results, we strongly believe that this is a safe and reliable surgical option for selected fractures. Thank you.
Hello everybody, my name's Natalie. I'm one of the ST4s in plastic surgery in Yorkshire. As you know, the introduction of lockdown meant an almost overnight alteration in the way that we delivered our services, and my presentation today is an overview of our experience in Hull after introducing a virtual plastics trauma clinic. So thank you for the opportunity to share this with you today. The aim of the study was to audit the new virtual trauma service that we'd implemented in response to the pandemic. Our model now consisted of all regional referrals being directed through a single referral point. So a smartphone was manned by either a consultant or a registrar, which permitted WhatsApp video calls and confidential image sharing for 24 hours a day. Patients were then triaged accordingly for either a face-to-face review, onward or direct referral to our therapy teams, or managed locally by the referring unit. An electronic patient record was created for every encounter, and we used this data to track patient outcomes. Specifically, we compared the unit's performance against the BSSH standards of care for hand trauma, along with complication rates at 3 months, as a way of objectively measuring the quality of care with this new model of working. We had 278 patients referred to us in the initial 8 weeks. Comprehensive virtual review enabled implementation of definitive management plans at the point of referral, and so reduced our clinic attendance by 40%. For the 166 patients attending, 3/4 were seen, assessed, and treated within 24 hours of referral to our unit. 98 of those offending for face-to-face review required a surgical procedure, and in 92% of these cases, the procedure was carried out on the same day as their face-to-face review. We achieved time to operative management as specified by your standards of care in hand trauma for all closed hand fractures, tendon and nerve injuries, and in 92% of open fractures. Patient records were reviewed for complication rates for those who underwent surgery, who were solely managed conservatively, or those who had initially been directly referred to our hand therapy teams, and we were pleased to report that no complications were found at 3 months follow-up. To conclude, our pilot model achieved a significant reduction in face-to-face contact and same-day service for patients referred. We are confident that we were able to continue to provide high-quality care as demonstrated by concordance with your standards. Our high same-day operation rate is attributable to the local anaesthetics theatre, which was already up and running in parallel with our trauma clinic, which meant that we could continue to operate independently of the pressures that were being encountered by the main theatres. We continue to implement the virtual trauma clinic today, but there are still challenges that we face going forward.
Okay, good evening and welcome to the discussion for session 1. My name is Colette Thompson. I'm working for Ormond Street. Not a lot of time, so we'll get straight on to the questions, starting with Tafiq. So just thinking about the grade 4 pulley injuries in climbers, I just wanted to know a bit more about what your outcomes were after pulley reconstruction, and on the basis of that, is there any particular type of reconstruction that you'd recommend?
We actually recommended the surgical technique for the grade 4 injuries, and depending on how severe the injuries we would decide, we usually try to do it with the loop technique, but all depends on the surgeon's personal choice.
And do you have any information about the actual outcomes that you have from these repairs?
Hi, can I butt in there? So I'm Mr. Raghavansit, senior author. I prefer the loop technique with or without the graft, usually as a thin palmaris graft. The fixation is the key here, and I tend to use a PDS to do a loop around create the new pulley. If it's a partial tear, then I can use I create a flap of what's left of the pulley to reconstruct it. But if it's completely torn, which it is normally in climbers, then I tend to use a loop technique. I have had mixed results in terms of long-term outcome because of adhesion formation and the fact that they just get stuck. It's a very fine balance between allowing them to move straight away, which is what you want to do, and to wait 4 weeks to allow the pullee to have some kind of substance and strength before you move them. So it's a very difficult balance, to answer your question, Colette. I struggle, actually, to be honest. I struggle between the two, and it's very much patient driven. These are very, very, this group of patients are very motivated, very driven, and they rehab very quickly, almost too quickly sometimes. But I tend to rest in a dorsal splint for about 2 weeks, and then we get early active going, but weekly monitoring by the hand therapist.
Okay.
Okay, thank you. Want to move on to LB. Thank you for, to Greg, sorry. Thank you, Greg, for your presentation. Impressive database, actually, from Birmingham. You mentioned the outpatient setup there that allows for 70% of your injuries to be managed within outpatients. Could you elaborate on what that setup is and how you can manage that volume of injuries in outpatients?
Yeah, absolutely. So it's a combination of the facilities, so a dedicated hand minor ops room using Wallant techniques to then be able to do your explorations and repairs, primarily the extensor tendon repairs, but we also do digital nerves under Wallant in the minor ops room. We've also done a couple of flexor repairs, but less frequently, just because of the desire for a more robust assessment afterwards. And then it's all about the personnel and making sure you've got the people on the ground to both be running a trauma clinic, but then have enough people to step aside to do those operations real time and get patients in and out the same day.
And is there any conflict in terms of income because you're doing these operations in a clinic as opposed to theatre?
So there was, but with robust discussion with management and appropriate coding. And then the key is we introduce things like the WHO checklist into this room, and then formal outcomes from the theatre sessions. Everyone gets a formal operation note performed on the same electronic database as what you do in theatre. Therefore, it all goes to the coders and it's all coded accordingly.
Okay, thank you very much. Colette?
Yes, so I'm next on to Ian's paper about the Manchester short splint regime. So I think if I understood it correctly, you're applying the regime to more complex patients other than what it was originally described as. So my question was there a difference in the outcomes between the
Yes.
individual simple injuries and then complex injuries, for example, with fractures as well?
Sorry, could you repeat the question? It was probably the internet, but
no problem. I was just wondering if as you're applying this regime to more complex patients than were initially it was designed for, did you find a difference in your results between the patients who were single flexor tendon injuries versus more complicated injuries?
I'm really sorry. I didn't fully get that. It must be the internet. I'm really sorry.
I tell you what, we'll
I think you're talking about simple versus.
Well, I'll type the question. We'll come back to you later on.
If we get a moment, we'll come back. LB Keeley, if I can move on to you, okay. with your paper on pediatric fractures. Thank you for that. Large numbers, over 300 patients. Did you consider using like a patient-rated outcome measure or correlating that to a clinical measure in this study? You do mention that there's no ideal functional measure right at the start of your presentation.
Yeah, I agree. It's a really useful thing to use a PROM, like a quick dash, as an adjunct. I think as this was a retrospective study, and it wasn't something that was included, and it also drew back on cases that had presented across 10 years. I felt it wasn't feasible to run a PROM in this setting, but it's something that we're thinking about running as a prospective study with more stringent follow-up in terms of timelines, and then a quick dash score or something similar as an adjunct would be really useful in that setting.
Okay, thank you. Thank you. Colette?
And then we're on to Deepak and the day case management of animal bites. So the key to the day case approach seems to be the effectiveness of your initial washout. And I think many would agree with that. So I wondered, what was the protocol for the thorough washout in A&E? What was that defined as? and how are you going to ensure that the level of that is going to be maintained so that it doesn't become more of a casual approach where the washout's insufficient?
That's a very good point, actually. So the washout in A&E is absolutely important, and it's mostly done by the registrar on call under local anesthetic with aseptic precautions, with good lighting in the A&E. So our entire premise behind this is a shift from an inpatient-based strategy to an outpatient-based strategy. And in fact, our protocol is still a process in evolution. And we're planning to take it forward into sort of moving away from operating on most of these. Like some of the questions I read said, do all animal bites need operations? The short answer is no. And even now, when they are assessed in the A&E, they are all discussed in the trauma meeting the next day, even if they're provisionally listed. And if there's any doubt by the person assessing them initially, they sometimes brought back for a review, a more senior review before actually going into theatre. So the next step, the logical step in our evolution would be probably doing them in a sort of MOPS setting without a formal theatre requirement.
Okay, thank you very much.
Okay, I'll move on to Theodora. Nice setup that you've got, and with the company that you've set up and these models. Neat idea. With the 3D printing. What are the costs of these models, and how does that cost compare to dry bones? That's the first part of the question. Second part is, really, should you be looking in terms of comparing the satisfaction of using your models versus dry bones or cadavers, and running a trial that way to see what is more effective as a training model?
Mm-hmm. Yes, of course. So basically, the major advantage of these models is that you don't need a special lab as we need with cadavers. So with cadaveric models, not only you don't have the fractures inside and you have to dissect and make the fractures while you do the course, but you also need a setup with the special equipment and people that will clean and prepare everything. So comparing the costs from previous courses, this is definitely less costly, the 3D printed models, and you can also basically design all the fracture patterns you want, customized on the hand model, and the silicone will go on top of that, so you don't have to spend a lot of time dissecting and making the bones while you're doing the course. Compared to just the normal bone models is quite equivalent, but the only advantage again is that you can 3D print the model with the fracture, so you don't have to break them. You can very reproducible make the fractures while you print it in advance. So
are you going to give us a cost as to what a typical hand model will cost?
I'm allowed to do that? I'm not sure.
Well, it's your company. I don't know. I mean, I'm just wondering, compared to the dry bones that the reps provide us to train on, is it quite costly?
Yes, so compared to the dry bones is less costly, I can say that.
Less costly?
Less costly, yeah.
Okay. So I guess the next step would be to have trainees trial both and see what they say. Okay.
And compare the two, yeah.
Yeah, thank you. Okay. Colette?
Yeah, so Deanna. Is Deanna, oh yes, there you are. I can see you now. So first we've got a technical question from one of the delegates. Do you split the central slip to insert the headless screw, and what size do you use for proximal phalanx?
We do a longitudinal incision in the central slip, and so far, obviously, we have measured the size of the screw based on radiographs. But so far for phalangeal fracture, we have used 2.2 screws.
Okay. And then the other thing that kind of I noticed was that the CRPS rate, you seem to say that there were 3 out of 26 patients that had CRPS. That's about 11% of your patients. So I just wondered if you had any thoughts on why that might be, because that seems quite high, and whether you still think your conclusion said it's a kind of a safe operation. Does the high CRPS rate change your thoughts on that?
Yes, as outlined in the presentation, all our patients that develop CRPS have multiple fractures, which were treated with this type of fixation. So probably a randomized control trial will answer the question whether or not this complication is due to this type of fixation or would have been with the extensive injury.
Okay. And then one more question. The IM screws are actually quite an expensive option. Do you have any information on the cost-benefit ratio between that and other more conventional methods of fixation?
As of now, this is just a pilot study in our unit, so unfortunately, we haven't looked into the cost, but that's a good idea to look into.
Okay, thanks very much, Diana.
Okay, Colette, do we have any success with Ian?
So yeah, I've sent Ian 2 messages through the chat. So I wonder, Ian, do you want to unmute yourself? Did you get them? Can you answer them?
Yes, to your question about did we find outcomes that were different with the Manchester short splint with the complexity of injuries we had, the answer is yes, we found a kind of a slight difference in the Manchester short splint did provide more complexity in trying to sort them out and with our outcomes.
I don't know if you can hear me better, but is there a plan for a multi-centre RC?
Hello? Hello?
Okay.
Yes, there is a plan for a multi-centre RCT at some point, hopefully within an IHR grant to investigate that a bit further.
Okay. Thanks, Ian. That's great. Back to Zaf.
Thank you. Thank you. So we'll move on to Natalie. Natalie, can you hear us okay? Can't hear you.
Unmuted.
Very low.
Any better now?
Just about.
Sorry.
Thank you for your paper from Yorkshire in terms of your virtual plastics trauma clinic, and I know that a number of units up and down the country, both in orthopedics and plastics, have tried various models during COVID. Now, you mentioned that 40% of patients were discharged following a definitive plan at the point of referral. Just can you elaborate on that? What does that mean? Did they get treatment locally without coming in to see you, or how did you manage that?
Yes, so that would either be treatment and follow-up locally with the referring unit, or they were patients that we were able to identify that could have gone to an elective hand clinic or dressing clinic within our unit but at our other site. So it was just total avoidance coming to our acute clinic, which would have been a duplicate presentation. I think we found previously referrals would be taken overnight. We would see them in the plastics trauma clinic as an extra attendance before referring on. So it was an unnecessary step in that way, or similarly with smaller injuries where the minor injuries units were happy and more confident to manage locally, it avoided coming to us entirely.
Okay, and I wasn't clear, just to finish off. Did you talk about were there any patients who came back despite the discharge? So was there a return rate?
The only one
using this system.
The only one that I can recall was a follow-up phone call with a gentleman who'd had a dog bite who was shielding, and so we'd arranged a follow-up appointment using the telemedicine service, but there were no patients who were re-referred with complications such as infections that were undertreated or anything like that in our numbers, but they were small numbers. Okay, fantastic. So I think that brings to a close the discussion session. We're doing well for time. I'd like to thank all of you from the various units who've put in all this hard work, especially during challenging times, to present, to submit your work and then to make the efforts of the video and present your work.
and congratulations also to all the senior authors who've supported you in this work, and good luck with the rest of your careers.
Hi everyone, I'm Lee Young, a plastic surgery registrar in Liverpool. The aim of this study was to review the outcomes of syndactyly releases performed in our institution by the senior author. It was a retrospective study, including patients with all types of syndactyles operated over a 10-year period. The outcomes we looked at included rates of web creep occurrence needing revision surgery, infection, dressing slip, and delayed wound healing as defined by an arbitrary time of 2 weeks. Patients with incomplete clinical records, such as op notes, or patients whose primary operations were not performed by the senior author, were excluded. We identified a total number of 84 patients with 161 webs. 22 additional patients were excluded as no operation notes was available. We have a relatively mobile patient population, which translates to an average age at last clinic appointment of 7.5 years and a similar average length of follow-up. This shows the breakdown of surgical techniques according to syndactyly type. Our standard flap is the stingray flap, which is used together with the skin graft if necessary. Island flaps are used when appropriate. We use skin grafts in 20% of webs across all complexities. Our overall web creep rate is 11%, with a slightly higher rate in the webs separated using the graftless technique. Moving on to our web creep rate, broken down into syndactyly complexity and surgical technique, we have a web creep rate of 20% in simple complete, 12% in simple incomplete, 50% in complicated, 2% in acrosyndactyles, and 14% in complex complete. This graph shows the different complication rates as a proportion of the age group in which the index procedure was performed, as indicated by the grey bars. Focusing on the graph on the left, which is the non-syndromic group, overall there were no complications in 62% of webs. 60 to 70% in this cohort are healed by 2 weeks post-op, as indicated by the purple line. Our data also suggests that age has very little significance on the complication rate. Now looking at the graph on the right, which is the syndromic group, there is a decreasing trend of complications as the child gets older, with the exception of delayed wound healing. The rate of delayed wound healing is greater than in the non-syndromic group. Overall, infection rates are low. In conclusion, we suggest that syndactyly release with all the judicious use of a full-thickness skin graft across all complexities is possible with good results. In the non-syndromic group, we would stick to convention that 1 to 2 years is a suitable age for syndactyly release, which is important for hand development. Timing for surgery in the syndromic group is very much dictated by the other medical needs, such as craniofacial surgery, but our data would suggest a decreasing trend in complications with the exception of delayed wound healing. Thank you.
For this study, we looked at the cost-effectiveness of the 3 main surgical interventions for Dupuytren's disease using a Markov model populated with data from the BSSH's own UK hand registry. This study is particularly pertinent given recent times where certain procedures may need to be prioritised over others, and in light of the evidence-based interventions consultation by NHS England. The 3 main surgical interventions shown on the left, used in the NHS, are the mainstay of treatment, which is limited fasciectomy, or LF, percutaneous needle fasciotomy, PNF, or dermal fasciectomy, DF. The aim of this study was to compare the 2 other surgical interventions in the English NHS to the mainstay of treatment, LF, as measured over the course of a lifetime. This is the first study in a public healthcare system, as well as one which compares all of the 3 main surgical interventions, and one that uses observational data to undertake decision analysis for Dupuytren's. Existing literature shown on the right has significant gaps, including a lack of accounting for heterogeneity, significant bias, limited applicability in other settings, and overarching assumptions made for the costs, utilities, and transition probabilities of the model. The model shown here mapped patients from the post-operative state following a primary intervention through to a post-operative state following a reoperation where applicable, through to death, over the course of a 34-year time period. We used a number of data sources from relevant and context-specific populations. Costs were obtained using the hospital episode statistics, made up of all patients admitted to secondary care in England, by producing costs for each patient's procedure and obtaining means. The same database was used to determine the probability that a patient had a reoperation using survival analysis. The probability of a patient dying was sourced from publicly available live tables, detailing the mortality rates at every age. Finally, health utilities were determined by calculating quality-adjusted life years from the EQ5D questionnaire by using UK coefficients to generate utility values for each follow-up time point for each patient. Once the model is run, the incremental cost-effectiveness ratio, or ICER, was generated. Using the ICER, limited fasciectomy was the dominant procedure, meaning it was the lowest cost procedure with the greatest health utility as a first-line treatment. At every willingness to pay threshold up to £30,000, it had the highest probability of being the most cost-effective. Further research can focus on the pathway beyond a first and secondary procedure through to primary care or beyond, using trial data, looking at the severity of disease, and looking at individual surgeon preference as well as regional variations. Thank you very much.
I'm Jenna Shepherd, currently an FY2 in Aberdeen, and I'll be talking about this study where we used statistical shape modelling to characterise trapeziometacarpal joint shape and assess how variations in shape of this joint might relate to thumb-based osteoarthritis. So we aimed firstly to develop a statistical shape model of the joint and then to apply this model to radiograph images of a cohort identified from the Osteoarthritis Initiative database. Then from this, we subsequently aimed to assess association between joint shape and clinical symptoms. And we did this using statistical shape modelling and developed a statistical shape model of the TMCJ. This is a 33-point model consisting of a template of points which define the shape of the base of first metacarpal and trapezium. As shown in this image, the points correspond to specific anatomical landmarks, and these can be mapped to individual images to define joint shape in each image. This allows comparison of shape within a cohort of images and to investigate variations in shape and association of these with clinical outcomes. Now, following model development, we then identified a cohort from the Osteoarthritis Initiative database. OAI was a multi-centre observational study, the data of which is publicly available and includes hand and wrist x-rays and clinical outcome data. To identify our cohort for this study, 1,000 bilateral hand and wrist radiographs from participants' baseline visits were extracted from the database, and a subset of 100 individuals' images were selected from this at random. The template of points was then applied to these images and the model was built. Analysis of this gives us modes of variation within the model, and these represent the variations in shape that are seen within the cohort. We then extracted mode scores for each image, which are normalized to the mean, and these scores are expressed as standard deviations from the mean, which is 0. We can then use these to determine whether the modes of variation in shape that are seen are associated with clinical variables. In this case, variation in joint shape was analysed for right and left hands separately, and these variations correlated with the presence of pain or stiffness in the corresponding hand. And so these pictures show plots of the base of first metacarpal and trapezium, and the different images represent the different variations in TMCJ shape that were seen. And this is shown for both left and right-sided models. Now, analysis of these using Spearman's rank correlation showed that this particular mode of variation is significantly associated with the presence of hand pain and stiffness. Now, the correlation coefficient suggests that negative values, represented here by the red line, are associated with symptoms. When we look at this anatomically, this is seen as a less prominent protrusion of the lateral joint surface of the trapezium between thumb and index metacarpals. And so we show that this particular variation in joint shape is associated with the presence of symptoms. This then requires further investigation, which includes assessment of whether joint shape is also associated with radiological severity of thumb-based osteoarthritis, which will then inform whether this model has a potential predictive role. Additionally, follow-up data for participants is also available, and we intend to explore this in due course. Thank you.
Hello, my name is Ben Miranda and I'm presenting Early Palmar Release in Aggressive Pediatric Camptodactyly, which is a project undertaken with Paul Smith, Max Horowitz and Cyrus Talwar. We propose early FDS release and gentle passive manipulation for rapidly progressive and aggressive camptodactyly in young children to avoid the establishment of firmly fixed adolescent contractures, which are more difficult to treat due to the development of dense fibrous adhesions. All patients should meet the surgical management criteria and a transverse palmar incision is made. The FDS is located and released at the chiasm level if intact proximally by flexing the digit, and this distal FDS release allows for FDS transfer to the radial lateral bands or correction of lumbrical abnormalities and dorsal apparatus adhesions if established. Early intervention means that the fibrous adhesions are minor and respond to intraoperative gentle passive manipulation, which is achieved by exerting sustained gentle PIPJ and DIPJ extension while holding the MCPJ in flexion. But if left for a few years, these fibrous adhesions will thicken and the volar plate and other affected structures will require surgical release. The child is splintered in the position of safety for 4 weeks with the PIPJ in full extension, and active flexion is commenced at 4 weeks post-operatively with night splintage used for 6 months. We looked at 24 release digits in 12 patients, 3 of which were syndromic cases and 3 of which were bilateral. And here we see how the progression of the camptodactyly was aggressive and rapid, and the surgery was undertaken within 3 months post-presentation with an average post-operative follow-up period of 2.5 years. The mainstay of treatment was FDS division and gentle passive manipulation, with 10 out of the 24 digits requiring this intervention alone. Contractures and range of motion arcs were significantly improved post-operatively, and 87.5% of patients achieved good or excellent C-good grades post-release. The unifying theory of camptodactyly proposed by Smith and Grobbelaar demonstrated that virtually all structures crossing the PIPJ are involved, and they therefore advocated using a combination of techniques, adopting some which had previously been established into their surgical approach. But this is significant surgery and not considered suitable for smaller fingers. Rather, it should be reserved for adolescent hands with established and firmly fixed contractures. Our presented results are promising, and if maintained during the adolescent growth spurt, will further strengthen the concept of early intervention in rapidly developing camptodactyly contractures in the young child prior to the development of firmly fixed contractures by dense fibrous adhesions. I thank you for your time and ask if you have any questions.
The title of this project is Why Scrub When You Can Mop? Taking Minor Ops Out of Theatre. And the work was done by the Orthopedic and Plastic Departments at University Hospital Coventry. The aim of the project was to evaluate the safety and efficacy of an emergency department minor operations suite to reduce hand trauma operating theatre burden. How we did it: first we established MOPS in our urgent treatment centre. This included a room with a trolley and an arm board, an overhead light, tourniquet, bipolar and a mini C-arm. We also created specific hand soft tissue sets with sterile services, and in those sets there were skin hooks, ragnals, dissecting scissors, nibblers, clips, needle holders, suture scissors. We then did a retrospective cohort study of all the hand trauma patients who underwent surgery with definitive intention in the MOPS over an 8.5-week period from the 23rd of March to the 20th of May. We defined our complications as unplanned ED reattendance or hospital admission or requirement for formal operating theatre management. Results: there were 191 hand trauma procedures. We categorized the diagnoses into simple wounds, bite injuries, fingertip injuries, fracture, extensor tendon injuries, foreign body, infection, and other. We averaged 3.2 cases per day, or 22.5 cases a week. But if you look at the graph on the right, you can see that as lockdown restrictions eased, we became considerably busier. We also looked at the duration of stay for a patient in ED, and the mean result was 140 minutes, with quite a wide range of 10 to 424. Looking at our complications, 3 bites, 3 infections, 2 wounds, 1 fracture, and 1 extensor tendon all represented ED. 2 of those bites required admission for IV antibiotics, and 1 proceeded for an unplanned formal washout in theatre. Fingertips, extensor tendon injuries, infections, bite washouts, and foreign body removals all had a combined success rate of definitive treatment in the MOPS of 92%. We calculated that this resulted in 98 bed days and 24.5 theatre sessions saved, with the optimistic assumption of 4 cases per session. Wounds, dislocations, and fractures had less savings, but we thought the care in the MOPS enhanced overall patient care. Limitations of the study: it excluded non-hands local anesthetic procedures, of which there were many. We also excluded complications for hand-specific outcomes such as stiffness and function. The patients had a variable follow-up period, and surgeon feedback was not included. In conclusion, establishment of a MOPS with adoption of Woulant technique and field sterility provided safe, definitive management of hand trauma during COVID-19. Specifically, fingertips, extensor tendon injuries, infection, bite washouts, and foreign body removals all had low complication rates and would be suitable to be managed at index presentation. And this is particularly relevant in the current climate to promote efficient use of resources which are becoming increasingly scarce. Thank you.
Good evening. I'm pleased to report our results on the use of elective fasciotomy for the treatment of symptomatic intracompartmental vascular malformations. This is work from the Queen Elizabeth Hospital in Birmingham. We know that vascular malformations are most commonly confined to the subcutaneous tissues. However, malformations can be located deep to fascial layers and, whilst rare, are often painful and symptomatic for individuals. This subfascial location further complicates and limits the use of standard treatment options for these conditions. We investigate whether selective fasciotomy could be a treatment option for the symptomatic relief in these individuals. We searched an established database from a super-regional vascular malformations multidisciplinary clinic to identify the relevant individuals. This was secondarily investigated alongside a trust ultrasound reporting database to ensure that no individuals were missed. Those patients with recorded compartment pressures were subsequently analysed. We identified 11 patients in total, of which 7 have been included in this analysis, and they have undergone a complete course of treatment, including selective fasciotomy. 4 individuals were male, and the average age was in the mid-30s. 4 of the 7 patients had previously tried injectable therapies with an average of 7 courses each. 1 patient had undergone a previous surgical ligation without success of their arteriovenous malformation. Of the 7 individuals investigated, 5 had low-flow venous malformations and 2 had an arteriovenous malformation. A consultant radiologist performed the guided compartment-centered compartment pressure monitoring, and this was performed at rest in a dependent position, and then post-exercise at 1, 5, and 15 minutes. The compartment pressures in the corresponding contralateral unaffected limb was also recorded. All measurements in the unaffected limb were normal. As per the Padovitz criteria for exertional chronic compartment syndrome, 100% of patients had an absolute pressure greater than 15 milligrams of mercury in a non-dependent position at rest. 6 of the 7 had a subsequent pressure greater than 30 immediately post-exercise, again diagnostic on the Padovitz criteria. Post-surgical decompression, it was felt unethical to repeat compartment pressure monitoring, as this would not have been routine practice in the treatment of acute or chronic compartment syndrome. 6 of the patients reported complete symptomatic relief, and the 7th patient reporting an 80% relief in their symptoms. Having previously been on complex multimodal analgesic regimes, all patients had no ongoing regular analgesic requirements post-operatively. They had a complete return to full independence of all activities, and 3 patients previously been unemployed due to their symptoms returned to full employment. We had no reported surgical complications to date in this patient population. So in conclusion, while some common deep compartment vascular malformations can be symptomatic and difficult to treat, elevated intracompartmental pressures can be recorded in this population, and selective fasciotomy does appear to be a good, effective, safe treatment for these patients. Further research, including collective reformal objective outcomes, is required and ongoing.
Hello, thank you for joining me today. My name is Dr. Matthew Wyman. I'm a junior clinical fellow in plastic surgery at the Northern General Hospital in Sheffield. Today I'm going to be talking about the role of serum inflammatory markers in the diagnosis and monitoring of hand osteomyelitis. The aim of this study was to investigate the role of white cell count, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and C-reactive protein in the diagnosis and monitoring of hand osteomyelitis. This was a retrospective observational study at a major trauma centre between 2008 and 2019. To be considered eligible, patients required a diagnosis of osteomyelitis of at least 1 metacarpal or phalanx, with serum inflammatory marker measurements performed at the time of diagnosis. The date of diagnosis was established based on the first positive bone biopsy or the first X-ray with bone changes. Diagnostic inflammatory markers were those performed within 14 days either side of diagnosis. You can see the reference ranges we used below. A total of 146 patients were identified. Most of the patients were male. The mean age of the cohort was 60 years old. Diabetes mellitus and end-stage renal failure were overrepresented. We found that markers were not universally elevated, and that CRP was the most sensitive of the markers analysed. We found that CRP greater than 100 was associated with signs of cellulitis and signs of sepsis. We found that CRP was useful in identifying patients at risk of amputation. A rise in CRP between diagnosis and follow-up was predictive of digit amputation. and a normal CRP at diagnosis had a high negative predictive value against amputation. The table on the screen in front of you illustrates the performance of CRP in identifying patients at risk of amputation of a phalanx and amputation of a digit or entire ray. In conclusion, inflammatory markers are not universally elevated in hand osteomyelitis. No single marker can be regarded as diagnostic. The role of inflammatory markers remains secondary to bone biopsy, imaging, and clinical findings in most cases. However, we did find that a CRP greater than 100 is a useful tool for identifying sepsis, that a rise in CRP at follow-up is associated with a higher risk of amputation, and that a normal CRP at diagnosis had a high negative predictive value against amputation, which should guide the counselling of patients. Thank you for listening to this talk. I'd be happy to answer any questions.
Hello everyone, I'm Rahul Bamal and I'll be speaking on our experience in wrist arthrodesis for spastic limbs using distal radius Vola locking plates. We have no conflicts of interest to be declared. The aims were to evaluate improvement in wrist position, hygiene, patient satisfaction, as well as complications related to the surgery. It was a retrospective study done over 33 months at Western Hospital and the Alder Hospital with a single lead surgeon. We had 8 wrists, with the average age of patients being 28 years and severe wrist flexion deformity of around 90 degrees. We used visual analog scale and the House scoring system for outcome scoring. VAS had 7 questions ranging from improvement in appearance, hygiene, daily cares, and overall satisfaction of the patient. The House scoring system focused on function, ranged from 0 to 8, 8 being spontaneous complete use. We used Medartis distal radius Vola locking plates for our wrist arthrodesis. The approach was standard 3-4 extensor compartment approach. PRC included excision of proximal half of capitate. We compared our study to the literature. A recent study with around 41 wrists from 2019 Journal of Hand Surgery done by Van Hees et al. They had averages of 22 hours for 28. The implant used by them was Synthes AO wrist fusion plate. We used Medartis Vola distal radius locking plate. The significant difference in the screw size with ours being 2.5, theirs ranging from 2.7 to 3.5 millimeter. Our implant also being a low profile. When we compare other parameters, the pre-op and post-op wrist position quite similar. Even the improvement in wrist position was quite similar of around 90 degrees. Fusion rates were around similar of 100%. Visual analog scale gave some outcome scores that showed significant improvement in appearance of the wrist, good improvement in hygiene, and overall satisfaction rate was quite high. Functional improvement was not that great, as also shown by House scores. Only 2 patients showed some improvement. The scorings are similar to as reported in the literature, with appearance, daily cares, and hygiene showing improvement. Also, the satisfaction rates. Functional improvement has not been that great. We had low complication rates in our study, no implant removals, no periprosthetic fractures, while the literature has reported on 36% implant removal rate. There were certain limitations to the study, ranging from small cohort retrospective study, recall bias and outcome scores, no control group, or randomization. We can safely conclude with distal radius variable angle Vola locking plates can be safely used for wrist fusion in patients with limb spasticity with excellent outcomes, impressive acceptability and compliance, low profile, and they help in achieving a stable construct, very low complication rate. They are suitable for small limbs or cerebral palsy patients, appear superior to presently available implants, and similar commercial implants should be made available for this patient group.
So welcome everyone to the discussion session. First of all, I'd like to thank all the presenters for doing such a fantastic job. Very well done for your excellent research in preparing the videos and in submitting your talks. My name is Yazan Al-Ajam, and I'm a consultant plastic surgeon from Manchester. And I'll be co-chairing the session with my colleague Jane McGehan, who is an orthopedic surgeon from Fife. So we'll try and get a couple of questions per speaker as per the first session. And I will start off with the first presenter. Li Yong, excellent paper, well done, 164 webs, that's an excellent number, all done by the senior author. And the first question is, do you think that these results are transferable to other surgeons? And was there a learning curve with regards to early versus late results of the senior surgeon?
Hi, thank you very much for your question. I didn't observe a difference in outcomes looking through the 10 years, although I'll be honest and say that I wasn't particularly looking out for it. But there certainly wasn't an obvious difference in terms of the outcomes between the early years and the later years.
Okay, so that's certainly encouraging, which means that the learning curve hopefully isn't as steep as we think it would be. The other question is for patients with APAS syndrome requiring multiple syndactyly releases, including the thumb, how would you normally stage these procedures?
So the way the senior author usually stages it is, in the first release, you would normally release the first and the fourth, and then the second and the third.
Right, so fairly standard approach for that then. And then finally, and just very briefly, how do you think your results compare with other techniques, especially with regards to the graftless repair?
Looking at the literature, our outcomes are quite comparable. Although it must be said that within the literature, they tend to divide the outcomes into complexity. So whether it's a complex syndactyly or a not complex syndactyly, and so the complication rates are divided across that, whereas ours is actually a combine of all types of complexities of syndactylies. But even then, our overall complication rate is comparable at 11% from what I've seen in literature.
Excellent, very good. Over to you, Jane.
Good evening, and I'm moving on to paper 2 by Gurdas Singh. Very, very interesting paper, Gurdas, and it's generated 2 big questions from the delegates, one of which is from the past president. First of all, you've used the BSSH database to calculate a cost per quality. So do you think that the demographics of the patients from which you have established the cost per quality are representative of the demographics of the population to which you have applied that cost per quality?
Yeah, really good question, thank you. So I think, firstly, the costs themselves, that was from hospital episode statistics, which we know is for every single admitted patient into secondary care. Obviously, the health utility data comes from the BSSH, which is you enter it yourself and it from participating surgeons. The thing that we did was compare the demographics between those 2 databases to see the similarities between them, and the differences between them weren't significant. So we can be reassured that they are quite similar.
Okay. The past president has a question for you, and he has asked, I'm just going to read it out. The cost analysis is taken from the perspective of the payer, i.e. state, but what about the secondary costs such as patients' loss of income with time off work, costs of personal and domestic support, lost tax revenue for the Treasury, all of which are much more for surgery than the P&F. Can you comment?
Yeah, of course. So I suppose with economic analyses, you adopt a certain perspective, and the one that I chose was a healthcare payer. All of those things are important, but they're beyond the scope of this project because you adopt a certain perspective. I think the reassuring thing is that this project's relatively novel in the fact that it uses observational data and it compares the 3 surgical interventions in the English NHS, which hasn't ever been done before. So the stuff that the past president's alluding to could definitely be built upon from what the outcomes of this project.
Yeah, the big data that you apply the cost per quality to is fairly limited, though, is it not, in its in the outcomes and scores that can be applied to it?
In what way? Sorry.
Well, there's no, you can look at gross data like readmission or complication, but it's difficult to look at these demographic and work-related issues from the big data.
I suppose there are some limitations in terms of like severity and people that are admitted, about the demographics of those. But I suppose it's really trying to get those starting points, and it's adopting it into a position that NICE can really use these outcomes from it. And very much what they care about is that incremental cost effectiveness ratio that we produce.
Okay, very good work.
Thank you.
Now, I'm just going to ask if Jenna Shepherd has joined us yet. And if not, then I'm going to hand over to Yazan from here.
Yes, I'm here.
Oh, sorry.
Oh, perfect. Go ahead.
Jenna, well done for getting to us. So we heard that you've been called back in. Very nice paper, and from an FY2, it's a very impressive piece of work. So the first question is, how do you think we as clinicians can use the work that you've produced here to inform how we treat patients?
Yeah, thank you. So I think at the moment we've established that there's a certain variation in joint shape that seems to be associated with symptoms. And I think the next kind of steps is looking at, we've established clinically, but also radiologically, whether there's a variation. And indeed, the next steps are we've got follow-up data from the Osteoarthritis Initiative, where the implications would then be, can we, applying these models to radiograph images that we get for patients in clinic or such, to predict not only severity, but then also using follow-up data, perhaps, can we predict development of symptoms and so on, to be able, both in counselling patients and in informing potential management options in the future.
How easy do you think it would be for a clinician to put that model into an X-ray that they get back from the clinic?
So I think, as with anything, it would probably be in the context of other clinical information. From a software point of view, having to learn the software, it's something that would potentially require a lot of work and education in terms of integrating it into clinical practice, I think.
Are there any other applications that you can see moving forward for this kind of data that you have developed?
Yes, well, I know we've looked at a very specific joint in the hand at the moment. The software and certainly that approach has been used across other joints, most specifically hip, knee, spine, but looking at, I guess, other joints within the hand, and then looking, as we say, further into its predictive role in terms of development of symptoms, which I think is probably more clinically where it has potential use.
Okay, thank you very much.
Excellent. I'll move on to our next presenter. Ben, excellent talk, very comprehensive. The first question is, do you think that the presentations at 2 years of age with some of these patients is much like that of a trigger thumb, i.e. it's rather that's the age where the problem is noticed rather than the actual time of onset?
So that's interesting, because obviously the general classifications are those that are congenital or adolescent, and I think that obviously there will be some patients that don't notice early, but in these cases, they are clearly cases that have been essentially pre-selected as being aggressive and advanced. So most of these cases have progressed by 30 degrees within a year period or less, or they have been in syndromic patients or in previously operated digits, or in fact recurrent cases that have been referred from other centres. So I think there is an element of pre-selection in the patient cohort that we have seen and that we were reporting on.
Okay. And the other question is, do you think that the manipulation that you describe, do you think it prevents joint changes, even in syndromic patients going forward?
So we haven't really looked at that, but I would certainly say that there is evidence in the literature, particularly with other conditions, that obviously if the joint is kept in an abnormal position for a long period of time and a growth spurt occurs, then this obviously does have a knock-on effect on joint changes. So yes, I would say so, but we don't have any data on that.
And then just very, very briefly, you mentioned in the talk about maintaining these excellent long-term outcomes during the adolescent growth spurts. What would you normally do to try and prevent it from happening at that critical time?
So I think this is something that we definitely would like to look at in the future. Obviously, the idea of doing this for these patients is that we restore an element of function back, and so therefore the procedure is a valid one to undertake. But you know, a much larger group of patients would be needed to follow as a cohort study through the adolescent growth spurt to actually see if it's maintained at that stage. Again, we just don't have the data on that, and obviously it's a relatively rare condition to see in these types, so in this particular type of way where it's very aggressive. So it would need multiple centres and multiple surgeons to contribute to actually get that answer.
Excellent. Thank you once again, Ben, for an excellent presentation. Over to you, Jane.
So have we Elizabeth Hedge online?
I'm not Elizabeth, but I'm happy to answer a question on her behalf. I'm not an author of one of the papers, but Elizabeth is on nights and having trouble logging in from Coventry, I'm afraid.
Okay, well, very nice to see you, and thanks very much for stepping in. So this is a very interesting paper because it comes out of the COVID crisis, and across the country, people have been finding very creative solutions to lack of staff and lack of theatres and lack of space. From my experience, a change in practice virtually always involves some sort of risk assessment, and I've found that managers are very risk averse compared to clinicians often. Did you come across any issues from that perspective? Managers?
No, honestly, no. I mean, we obviously had the heads up that things were going to change very rapidly, and as soon as we knew that the hospital services were going to change dramatically with all the COVID patients being admitted, we just came up with a plan ourselves to move the hand service to our local sort of treatment centre, our elective hospital, and we converted a resus area into a minor ops theatre, complete with mini C-arm, and we created some kits for hand specific hand surgery theatre kits. No, the managers were on board, really. We met with everyone we felt we had to meet with, but there were no specific concerns raised, and our backup plan was always that we could go to main theatre if there was a problem.
Yeah. So the main theatre, the way things run a situation, do you think it's the local anaesthetic that has created the saving in theatre space? Is it the moving to a local anaesthetic model, or is it the moving it out of main theatre?
It's probably mostly being out of main theatre. This resus area was just directly adjacent to the minor injuries unit, and yeah, we didn't have to admit patients to wards. We didn't have to go through a day case unit, so they came into minor injuries and they were moved along straight to the resus area and operated on there and then.
Thanks very much. We better move on. Back to
Excellent. Yeah, thank you very much, Jane. Question to Greg. Excision of the fibroadipose vascular anomalies, the FAVAs, results in significant loss of muscle bulk. Do you have any experience of compartment release in these patients, and if this relieves any pain?
We don't, is the honest answer. And I say this is a new kind of avenue of treatment we're exploring, starting off with the slightly more common patients that we're getting through our MDT. I mean, in theory, it's a space-occupying lesion. I suppose the difference there is whether it's increasing in size post-exercise or flow, which is increasing the compartment pressure, which is increasing the symptoms, whether it would be a benefit or not. Given that the majority have raised pressure at rest, however, if that group was shown to have similarly, there's no reason why it might not help.
Excellent. Thank you for that. And then just moving on very swiftly to our next speaker. what were your microbiological criteria for diagnosing osteomyelitis? Was it kind of the typical 2 specimens out of the 5 bony specimens, all growing the same bug, or did you find that you were using a different criteria?
So our criteria for selecting these patients, we found that because obviously the small bones of the hand potentially be compromised if we were taking 5 samples from the same bone. We use a pragmatic approach, so we use a combination of clinical findings, radiological findings, as well as microbiological samples. So the majority of our patients did have microbiological samples, but we know from the literature that a small number of patients will get negative samples despite having clinical findings of osteomyelitis. So we use a pragmatic approach to diagnosing the disease.
Very good. Very well done. Excellent presentation. And over to you, Jane, for possibly one more question for the last speaker, please.
Yes, this is a question for Rahul. This is a very nice series, and the first time I've seen this plate used in this context, Rahul. Did you have to do any tendon releases, or did you find that the proximal row carpectomy was in itself enough to provide the length that you needed to get the plate on?
Hear me now. In all the cases, almost all the cases, we did the proximal row carpectomy, but many of them required at least flexor carpi radialis and FCU release, and we released pyomitis longus along with them mostly. Some of the cases also require flexor digitorum superficialis release and the FPL, because many hands are not functional enough, and those releases can be done safely.
Yeah, you did say that the patients didn't have much in the way of functional improvement, but the hygiene was much better. But that was a very elegant study, so thanks for that. I don't think there are any more questions, Yazan. Can I confirm?
No, I think that's it. Thank you everyone for contributing, and to all the members of the audience that sent in all the questions. It's been a very lively debate, and we are literally on the last few seconds of airtime for the second session, and with this we conclude the session, and we can hopefully take a mini break and then go on to session number 3. So thank you ever so much for everyone who's put in all the time and the effort to make this such a success. Thank you.
Thank you.
Good evening, I'm Ben Dean presenting this talk on behalf of the Oxford Base of Thumb Collaborative. So over the past couple of decades in the UK, there's been a fair bit of change in service structure. Interface services have kind of sprung up and evolved as the traditional model of GP referral director secondary care has largely been replaced by one in which interface services play a key role in between. The aim of this project relating to base of thumb arthritis was to assess what treatment patients had had before referral to the interface, and assess the service structure and pathways for base of thumb arthritis within the interface. We had 32 participating centres and 5 patients per centre, as well as a clinician survey at each. So unsurprisingly, of our 160 patients, the majority were females and first-time referrals. Most patients had been treated with analgesics, but not with a splint therapy or an injection. Based on numbers of referrals at each centre, we calculated there are over 50,000 first-time referrals every year in the UK. Of the 32 participating centres, 11 were purely hospital-based and 21 had a community-based component. The referrals were generally from primary care, but an increasing proportion were taking self-referrals from patients. Staffing mix was slightly different. Physiotherapists and occupational therapists generally were present in the hospital units, while physiotherapists and doctors in the community units. So in terms of the management of base of thumb arthritis, it was fairly standardised in some key ways, particularly in terms of therapy, education, joint protection, exercises and use of assistive devices. However, it was highly variable in some ways in terms of the use of PROMs, the clinical threshold for steroid injection, the mode of injection delivery, drug types, doses, post-injection advice and follow-up was extremely variable. There was a dramatic shift in the way patients were assessed from face-to-face for the first appointment to 100% virtual, either video phone or a mixture of video and phone. Injection services were significantly altered. Only 2 centres continued injections, the majority stopped and then had restarted or planned to restart at some point in June or July of 2020. Here you can see our key conclusions. Basic thumb arthritis represents a huge disease burden. The interface management of basic thumb arthritis is fairly standardised in some ways, but highly variable in terms of steroid injection use and delivery, and the pandemic has resulted in some clear changes in assessment. Many thanks for listening, and to all those who contributed to this project. Thanks.
My name is Samir Guttrell. Thank you for allowing us to share our work on prisoners with hand injuries. The problem as we saw it, hand injuries are commonplace in prison with things like alleged assaults. Prison inmates attending hospital, they require prison escort that comes at cost to the prison and reduces the number of guards on site there. Also, they often require multiple attendances to ED, to X-ray, to the hand trauma clinic on another day, to come in for surgery another day, and then to see the therapists. This is decidedly inefficient, and historically DNAs were commonplace. We aim to look at our current service in the region for prisoners, then streamline this care and analyse its impact. We did this by way of retrospective audit in our region. We then implemented our new pathway and then prospectively re-audited the findings. To do this, we delivered an education package for GPs outlining common hand injuries and combined this with a traffic lighted triage tool to allow a pathway of care to be generated. We then gave the GP prison doctors a direct line of communication with our plastics trauma clinic, and on the day prisoners came to see us, tried to offer a one-stop shop with X-ray, trauma clinic, theatre and hand therapy all in one if needed. We assessed outcomes such as route of referral, the number of appointments needed, number of DNAs, the days from referral to assessment, and potential cost savings. Initially, we found we were seeing about 4 prisoners a month, and we analysed 33 cases before and after implementation of the new pathway. So comparing the old system to the new system, we saw that ED referrals fell from 52% to 0%, which was great, as this meant prisoners were bypassing ED and not waiting there. GP referrals from the prison went up from 25% to 100%, again meaning they were coming straight to us. Pre-booked X-rays for prisoners on the day of their visit went up from 0% to 100%, and the same day hand therapy went up from 25% to 2/3. We reduced the number of appointments prisoners needed and reduced the number of DNAs from 1 per prisoner to less than 1 in 3. And the number of days from referral to being seen went from 9 days to 2 days. We were slightly limited in that we had small numbers, and this was initially retrospective. We can't also comment on any clinical benefit to patient outcomes from this pathway yet. But in terms of cost savings, this was in the thousands, and we looked at the number of appointments that were saved, the number of DNAs that were avoided, the number of ED attendances that were saved, and the time prison guards saved by not having to bring the prisoners in. This totaled over £30,000 in terms of savings to the trust and to the prison service, and we're able to do this with fewer visits, fewer DNAs, and with a quicker time from referral to review. In future, we'd like to re-audit our service, continue the education package for GPs, and roll this out to other hand units, which we've started doing. Thank you.
Good evening. I'm pleased to present our study from the Royal United Hospital, Bath, looking at the accuracy of the Shuck test in the assessment of distal radioaljoin instability. DIUJ stability can be assessed in various ways. Clinically, this is classically performed using the Shuck or ballottement test, which assesses dorsal palmar translation of the distal ulna relative to the distal radius. This can be supplemented with investigations. We've developed a mechanical jig that formally quantifies this DIUJ translation. We've used this in over 500 individuals and published it in the literature. Previous studies have suggested that Shuck test is a reliable means of DIUJ assessment. Our experience using the jig suggests otherwise. Our aim was to evaluate experienced clinicians' ability to assess DIUJ stability clinically. 4 volunteers, themselves all hand surgeons, with stability proven with our jig, agreed to participate. 1 volunteer had bilateral DIUJ laxity, secondary to hypermobility. 2 individuals had unilateral DIUJ laxity post-trauma, and the final participant had bilateral normal DIUJ translation. Both limbs in each individual were assessed, and this was performed in a warm room at a recent BSSH meeting. Final outcome was for a clinician to record if they felt each individual joint was stable or unstable. 30 specialist hand surgeons, a number of which are probably watching this evening, agreed to participate. Any clinical technique was permitted, however, all utilised the Shuck test as their primary method of assessment. It should be noted that there were many variations in technique, including the use of hand and forearm positioning to try and aid their decision making. 80% of those partaking were male, and the majority were of an orthopaedic background. They had a combined 468 years of consultant-level hand surgery practice. Our ability to detect instability was poor, with a sensitivity of only 24%. However, specificity was high at 94%. Where instability was detected, it was generally correct, with a positive predictive value of 81%. However, the majority of instability was missed, and therefore the negative predictive value was only 55%, or just better than a 50-50 chance. No surgeon correctly identified the stability of all 8 limbs. There was no correlation between background orthopedic or plastic training in your ability to detect stability. There was no correlation between years of experience and accuracy of assessment, as demonstrated by the scatter plot here. In conclusion, clinical assessment of DIUJ instability amongst experienced UK hands clinicians is unreliable. Clinicians typically under-recognise instability. Previous research to date using this clinical assessment method as a parameter of success is therefore brought into question. Use of our jig as feedback has improved our reliability, highlighting the importance of measurement in any clinical test. We are developing a method of improving clinical reliability using our jig. Thank you.
Hello, I'm David Plain from Leader Orthopaedics. We are the exclusive UK distributor for Skeletal Dynamics, Dr. George Orbey's innovative upper extremity company. As many of you will know, Dr. Orbey popularised the Vola approach for the treatment of distal radius fractures with the invention of the DVR plates back at the turn of the century. The Geminus is the evolution of this system, and it gives me great pleasure to introduce you to it today. As well as the Geminus Vola plate, the system features dorsal fragment-specific protein plates for the radial and central columns and the dorsal spanning plate for polytrauma and highly comminuted fractures. The Geminus has a low profile, dual-head fossa-specific anatomical design which aims to protect the flexor tendons. Carefully calculated fixed-angle screw trajectories allow the best subchondral support essential for an optimal result. We have smooth pegs, locking and non-locking threaded screws, a polyaxial screw option, and a high compression screw, which uniquely provides 1.5 mil of dorsal fragment compression from the volar side. Efficiency and accuracy in the operating theatre is key. These unique aiming guides show you exactly where your screws will go, ensuring proper plate placement while aiding fracture reduction. And the now famous hook plate extension of the Geminus allows elegant fixation of any volar marginal fragments and locks straight onto the plate when required. Because not all fracture patterns are the same, this unique free fix technology allows locking screws to be used in dynamic holes to compress any diaphyseal fracture extensions. This is a brand new addition to the plate profile. And if the dorsal approach is required, or you need to fix the distal ulna, all scenarios are catered for with these low profile, fragment specific protein plates. Launched in 2020 to further improve the kit, they can be easily manipulated in all 3 planes to customize them to each patient's anatomy. The protein pliers allow you to address the plates from above after initial fixation and makes Geminus the only system with on-bone, in-situ contouring. And as you can see from Dr. Orbey's demonstration here, the plates are extremely robust despite being adjustable. Dorsal spanning plates can be a very attractive option for some patients, and the Geminus system offers this option on the same tray. Anatomically designed to avoid Lister's tubercle, the dorsal spanning plate has a shovel tip to aid insertion via a percutaneous technique with an ergonomic handle. It has a solid central portion to avoid stress risers over the radiocarpal joint line and avoid bony ingrowth, making later removal much easier. The Geminus system is simple yet comprehensive, and has been adopted by major trauma centres and specialist hand units around the UK. Leader Orthopaedics are privileged to distribute this system and proud to present it to the BSSH. Thank you.
Thank you very much, Gronya, for fantastic chairing this evening. This is the last bit. So what we're going to do is we're going to ask the 3 candidates for the prize. It's 500 quid, so no pressure then, everybody. We'll ask you some questions. Then at about 1 minute past 9, Kavita's going to set up the vote. If you look at your on-air screen, there's a column to the right-hand side, and it allows you, when Kavita turns it on, to actually click who you think is the best paper, okay? So when it's turned on, you can click the best paper, and think of the paper, think of the answers to the questions. And what we'll do is that my colleague Roa here is going to ask the first question or 2 of each candidate, and I'll ask any audience questions that come through. So Roa, over to you to give the first set of questions, please, to Mr. Dean, to Ben.
Great, thank you, David. Thank you for your excellent presentation. I'd like to start with you, Ben. That was a really comprehensive evaluation of care, or particularly of in the interface services, as you stated. I'd just like to know, how are your 5 patients selected, and how do you know they are representative of patients with basal thumb?
Yeah, so we just gave very simple instructions to the therapists taking part. So they just gathered data for 5 prospective patients. So it was representative roughly of the patients they saw. Obviously, you'd ideally like a bigger sample, but obviously if you're doing a service project, then the more you ask for, the less likely you are to get people to actually complete the data set. Mm-hmm. So yeah, it wasn't random 5 patients, it was 5 prospective patients. So we got a fairly representative sample of what they see day to day.
And as it was left to each individual unit to identify their 5 patients, is there not a risk that it introduces some element of?
No, they did 5 consecutive. Well? They did 5 consecutive patients. So it's 5 consecutive prospective patients. So.
Okay, thank you.
Yeah.
And as we mentioned, it's a great piece of work. And what is it going to lead on to next? What have you got planned next for evaluation of these injuries?
Yes, we're just doing some qualitative work now, just exploring people's perspectives on how to go about a trial, really. So I think injection therapy, we don't really know if it's effective and what the role is of injection therapy. So I think probably the role of injection therapy is particularly interesting. When should we give it, alongside what and to who? And perhaps a randomized trial comparing injection with either no injection or some kind of placebo would be something we'd be quite interested in. But obviously we want to do that effectively, and working out where the facilitators and barriers are is probably the first step to go in that regard.
Okay, thank you.
Ben, I've just got a question for you.
Yeah.
The interface units are very common now. And did you get a feel for whether interface units, the proportion of patients who are likely to go to the interface unit, get their injection or get their splint, get their OT advice, and then they never hit secondary care, and which proportion may actually go through that and still end up in secondary care?
Yeah, something I thought about doing. Problem is the majority of centres didn't have any kind of data on that, but I did chat to all the therapists at each centre, and it is a minority that do get referred on. And just starting the qualitative work now, I'm having kind of detailed chats with each therapist for an hour or 2 and kind of exploring that. It does seem, a lot of patients some patients want surgery and push their way through to surgery, but that's quite a small minority. A lot of patients are quite happy to battle on and have repeated injections over years. We often, in secondary care, we never see those patients. So I guess we're all kind of slightly biased depending on where we work, but it's definitely a very small minority that end up coming through to us.
And that's a mark of the success, I suppose, isn't it? The more that stay there and never darken our doors, the more successful.
But we don't really know what's the best timing of all our interventions, because it may be, we tend to inject 2 or 3 times before we offer a trapeziectomy in the UK, but we don't really know when to offer surgery, when it's most effective, or should people have 1 injection or even more, or should surgery be offered earlier to some patients? We just don't really know. So yeah, I think that's kind of a good avenue for further research, the timing of surgery.
Perfect. Right, I think that's. Thank you very much, Ben. And then back to Roa. It's time for Sam to have your grilling now, Sam, for that £500.
Great, thank you, and thank you, Sam. And it's very useful for us to evaluate our services and try and identify cost cutting where we can in the NHS. I just want to know, have you quantified these improvements in terms of the financial cost against sort of to identify a cost benefit, bearing in mind the cost of implementation of your pathway versus the cost savings that you've identified?
Thank you. Well, there were really no setup costs for this pathway, and I think we were very lucky. There are lots of low-hanging fruit we could grab onto to just improve things all around for this very specific, vulnerable small group, and it worked, I think, because it was a small group. So by improving communication with the GP service and the prison, that was by way of email, that was cost less. The education package was delivered by our lead consultant, so I guess that might bite into SPA time, perhaps, but the ongoing education from that point of view, the GPs have now put it online, and so the prison staff can now access it. So again, minimising costs there. And in terms of having prisoners come through in a shorter period of time, not spend as much time in hospital and have fewer appointments, we're not incurring any costs. And again, we're saving. So there were no real setup costs.
Okay, thank you. And did you get any feedback from those within the prison, so the prison officers themselves, on their views on this new streamlined pathway?
Yes, I sought to get some feedback, and one of the GPs commented that it was essentially a game changer for them. But in the past, they were sending faxes through to what ended up being the orthopaedic fracture clinic that would then come through to plastics, and we'd take 9 days to get to see some of the prisoners sometimes. The prison governor actually commented on how useful it was for the prisoners to not have as many appointments, because as soon as guards are taken away from the very under-resourced prison, there are issues with them, with the prisoners undergoing supervised education and exercise, which can lead to disquiet and therefore more riots and more injuries. So that was beneficial. Interestingly, prisoners gave slightly different accounts, again, coming through from feedback from our GP colleagues. Some don't actually like going out in cuffs and find it quite sort of demeaning and preferred fewer appointments, where others might see it as a day out and wanted more visits out to the hospital. So variable. And we did want to include the prisoners in our pathway development, as you'd want to include any patients or stakeholders in your entire pathway. But the problem was we couldn't involve them too much because they might plan some sort of escape.
And just following on from that, one final question, by prioritising these prisoners, are you taking that time away from other patients who potentially have to wait longer because you've prioritised the prisoner?
That is a good point. But what we hope is that we are trying to help this already vulnerable population that are having delays to being seen, and actually trying to equilibrate what would be normal PAR service for others. And also, if we minimize DNAs, then we're going to be able to use those slots for other people. And also, if we speed their throughput through the hospital, again, less time in hospital in say COVID times is good, because there's less chance of transmission with fewer people around. So I think there are lots of peripheral semi-quantifiable benefits too. So I'd hope that wouldn't be a sticking point.
Thank you.
As ever.
Oh, apologies, Professor Ork, I think you're on mute.
I'm always on mute. One quick question, and then we'll move on to Ben.
Yep.
But could you see this pathway being used for other groups, for example, care home residents, as a model?
Yeah, absolutely. We could use a streamlined type pathway for specific groups, and I think it works well for small numbers, because we are sort of doing a little bit more for that group. So small numbers that are particularly vulnerable that could benefit. And also we could see this model being rolled out to other units, and my senior author has said that it's been taken up in principle by Salisbury, and Rampton Secure Unit have approached us to emulate it as well. But yes, there could be a role.
Well, that's exciting. So thanks to Sue, the real president, for the first question about prioritising, and thanks to Katie Hilda for the second one. Now, Greg, this is it. This is your final chance to earn 500 quid.
Thank you, Greg. Thank you, David, and thank you, Greg, for a very interesting presentation. It's a little bit, it's an eye-opener to see how inaccurate we are as surgeons in assessing our patients. And I just wonder how you assess for inter-examiner variability, because you mentioned in your presentation there was considerable variability in the forearm position, in the hand position, and did that have any impact on the accuracy of the assessing?
Yeah, absolutely. So it was very interesting, as being one of the volunteers assessed, to watch how people were assessing individuals. the common denominator was the Shook test, but then many people did perform the Shook test with the forearm in pronation, supination, or the hand deviated. We didn't actually find that those people were more accurate, unfortunately, but that is something that with greater detail we maybe could look at.
Ro, I think you're on mute.
Thank you. And just one final question, if I may. What do you personally use for when you're assessing the Shook test?
Yeah,
well, we're also inaccurate at assessing instability.
Yeah, so I think the important thing here is that we still feel the Shook test is the best test to use, and the evidence would suggest that. What we're more kind of suggesting is, like any good kind of scientific piece of instrument, it needs calibrating, and we maybe just need to calibrate people's ability and assessment of what they're perceiving as lax or unstable or greater than usual. It wasn't possible to put it into the presentation, but people were much better at the volunteers with the asymmetry. So people were good at spotting asymmetry. Unfortunately, a number of people spotted it the wrong way round, but they were able to spot asymmetry better than the people with bilaterally similar wrists. So I think it's more a case of I use the Shook test, and it's more a case of just refining your Shook test. Interestingly, the same person using the Shook test over a long series of people is likely going to be consistent on their own internal validity because they're perceiving in their own mind what's unstable. It's just the bigger picture where they may be underestimating instability.
Thank you. One final question. It's just regarding the JIG that you've highlighted as the potential gold standard. How has that been validated, and how do we know that that's a gold standard for assessing instability?
Yeah,
I know you've published on it already.
Yeah, so it's validated just by its frequency, its use, and its correlation with the other studies in the literature that look at CT, for example, or ultrasound or MRI with regards to the values being obtained and its accuracy in that sense. But you're right, it's only one piece of kit, and it's as validated internally as it can be. All
right, a couple of cheeky questions here for you, Greg. Bound to be at this time of night, I suspect. But one of them is, I think, from one Mr. Rob Poulter, about have any of you phoned a friend in the background? And if so, make damn sure you share the 500 quid with them. And yeah, so that's something to think about. I think what we're going to do at the moment is we're just about to go on to the vote. So Cav, you're there, I think. And if Kavita, you could set up the vote. I think, should we give them a minute to vote, Cav?
We can do, yes.
What time's the session end altogether? So we'll give you a minute to vote. Cav, sending up. So you go back to the events there, and if you have a look, the column.
9:04.
Okay, so you've got a minute to vote.
Okay, so I'm hitting vote.
Off you go, everyone. You can vote for who you think is the best. And you can all see the green bars going up and down and up and down. That's it.
And the winner is?
Well, the winner is Samir Gurjal. Very well done. And there's a disadvantage of winning is that you've got to buy the current president, Sue, and the ex-president, Abir.
How about a curry?
The curry's even better. You could buy us all a curry in Exeter when we all meet up in April, because that's going to be the next thing for all of us as a society. So if I may, I'm just going to wind up on behalf of everybody. First of all, this took an awful lot of organising, and I've got to tell you how much work that Kavita has had to do to stitch all your videos together and then integrate it into event. So I'd like you all to do a digital clap for Cav. The other thing is that Dominic is an absolute star. Professor Dom Furness from Oxford, absolute star. And again, he's been brilliant in the background setting this all up. Gronya has been the perfect navigator and host this evening. Thanks to all of you lot who've done papers, and thanks to your supervisors, and thanks for presenting. Thanks for the chairs who've all done an amazing job. It's a bit of an artwork just to do all this chairing stuff, and I think all the chairs today have done brilliantly. Finally, make sure you look at the next book that's online. All the papers are there. And we have had two sponsors tonight. Dupuy and Leader have each given 1,500 quid, which goes into the BSSH coffers. Every penny counts. And in addition, Leader provided the £500 prize that Sam's going to spend on curries for the entire BSSH membership when we meet later in the year. So thank you all ever so much. You're going to be in absolute brilliant hands this year with Sue Fullylove as the new president. So it's been a pleasure to work last year, and even more of a pleasure to give it all over to Sue for next year. So thank you all. Good luck. Stay safe and God bless.